Welcome, everyone. This is my pleasure to welcome you today on behalf of the International Society of Nephrology Renal Pathology Working Group. So we have another seminar today about kidney biopsy in the management of lupus nephritis, the evidence and the gaps. Thank you.
Okay, first of all, thank you very much for the invitation to be with you today. Thank you for this kind presentation, Professor Avila-Casado. So in the session of today, along with Sonia Rodriguez, we will go through the kidney biopsy used in the management of lupus nephritis, and we will find that there are some evidence places and there are still some gaps in there. These are my disclosures. I have nothing to disclose in relation to this talk, and Sonia Rodriguez has nothing to disclose. And the objectives of today's talk is to explore the role of the kidney biopsy as a tool to guide therapeutic decisions in lupus nephritis. And for this, we will go through a real-life case, and we will revise the use of a kidney biopsy for initial diagnosis as a tool to evaluate response to therapy, for evaluating relapsing disease and treatment suspension. And in these case scenarios, we will discuss the limitations and the gaps in knowledge. Before going full into the case, we will revise some general principles for the use of a kidney biopsy in lupus nephritis. And as you know, we refer to the lupus nephritis as the common immune complex deposition disease. And this is the one that we classify with the International Society of Nephrology and Renal Pathology Society, ISNRPS classification. I will refer to this as the classic lupus nephritis, the immune complex deposition disease. But as you also know, there are some other forms of affection of the kidneys in systemic lupus erythematosus. And these are what I will call the non-classic lupus nephritis, and includes lupus podocytopathy, collapsing nephropathy, thrombotic microangiopathy, and interstitial nephritis. So let me give you 3 points about the use of the kidney biopsy that I believe that are important. The first one is that the clinical presentation of the immune complex mediated lupus nephritis is highly variable. It can go from an asymptomatic disease manifested only by isolated hematuria or proteinuria in the urinalysis to a rapidly progressive glomerular nephritis or a nephrotic syndrome. And we usually, and many tests that we do in our lab, the USMLE and many others at your local universities, always make this question about a patient with an asymptomatic disease, and we usually think it may have a class 2, for example, lupus nephritis, or a patient with nephrotic syndrome. We believe this patient has a class 5. The reality is that some studies have gone through this, and the prediction based on clinical findings is inaccurate in many cases. And this is an example. This is one study, and you can see here the syndrome of presentation of the disease, and here the ISNRPS class. And for example, patients with asymptomatic urine abnormalities, look at this. There were patients with class 5 lupus nephritis. We wouldn't think of that usually. And the activity index was really high. Another example, patients in this study who presented with nephrotic syndrome, the most common cause was a class 4 lupus nephritis. So prediction based on clinical findings is frequently inaccurate. So if we want to know precisely what class of lupus nephritis we have in front of us, we need a kidney biopsy. What happens to the non-classic forms of lupus nephritis? We really don't know, but we think that presentation is more consistent. For example, lupus podocytopathy usually presents as a nephrotic syndrome, interstitial nephritis as an acute kidney failure, collapsing nephropathy as a severe.